Awesome. All right. So once again, welcome back to Thirsty Thursdays. If this is your first time joining, welcome. If this is your repeat, you're coming back. You're dropping back in to join with me on Thirsty Thursdays. Welcome back. If you are watching this video because you weren't able to attend, guess what? It's okay. I appreciate you watching, and hopefully you can take away some things. We're going to have some fun today. Our focus is on the category of reduction of risk potential. Several of you that are in here today, that is the topic for the week that we've been focusing on, or at least that we focused on earlier. So I want to continue in the lane of reduction of risk potential. I want to remind you that this section focuses the nurse on reducing the likelihood that our patients are going to develop complications. It could be secondary to health problems that they already have, or maybe treatments or procedures or tests that they're undergoing. Our job as nurses is to make sure we can reduce their risk of complications. And if you recall, a lot of that is seen in the form of vital signs, lab values, and so forth. So we're going to continue our efforts and do questions today centered around this topic. All right. So once again, I'm happy to have you. Some rules of engagement. They pretty much are pretty standard, the rules. For every question, it'll be 1 minute and 30 seconds for you to answer. That is consistent with the time frame in which the NCLEX gives you, or they're suggesting that you spend about 1 to 2 minutes, right, on a question. So about 1 minute, 30 seconds is kind of the sweet spot. So we're going to use that time. I want you to put all your answers in the chat box. Please make sure that you remain muted because I want to make sure we're not distracting others. Again, if you are moving around on your camera, please take it off because it can become a distraction to others. When you put your answers in the chat, I need you to use letters, all right? Not numbers. So please make sure you follow that directive and don't overthink it. We're here to have fun, and we're here to get more exposure to these questions at hand. All right. So some strategies, a few things that I want you to make sure that you remember. To best answer these questions, you are going to need to know vital signs, right? Especially the normal, so that you can identify abnormal, right? In the question, you will also need to be familiar with the lab values, right? Particularly the normal, so that when you have questions come up, you can identify those abnormal. The nice thing I want to just tell you that I sent out an email blast about maybe 20 minutes ago to remind you of today's class. And I attached to that email a resource for you all that has tips and tricks to remember lab values. All right. So I do want you to check that out. That's like a bonus resource for you. It has a lot of good information. So please check for your email within the last 30 minutes. Something came out from me reminding you of today, but I did attach a nice little treat for you there to check it out. All right. So make sure you do that. Once again, also strategies on how to answer these questions is being familiar with diagnostic tests. There are common ones out there like EKGs, CT scans, MRIs. There are also procedures like cardiac catheterization. Being familiar with those particular test procedures are going to be very helpful because you're going to see questions, and you're going to see them today that connect some of those procedures and tests to questions, and you're going to see how they present. But being familiar with them, and just to remind you, in your packet, right, page 33, there is a list of those commonly tested diagnostic tests, procedures that I want you to make sure you're combing through and exploring. For my March cohort, we haven't gotten there yet, but we're going to get there. So this is kind of a preview of what reduction of risk looks like. All right, looking for evidence in your question that your patient is in distress. And obviously, if they are in distress, that's a problem, right? And we need a solution. So remember the method of problem, solution, as well as don't be so quick for your solution to be to call the primary care provider. There will be questions where you will have to call them. All right. But remember, the NCLEX is testing your decision, your ability to make decisions. And it may not always be to just call them immediately, right? It may be something that we as nurses can do within our scope to solve this patient's problem. All right. So let's get into it. The more you practice, the better you're going to become, the more confident you're going to be as you tackle these questions ahead. All right. So let's get into our first question today. I'm going to read the question. You're going to read the answer options to yourself, but you're going to drop your answer in the chat as I mentioned. All right. So this question says a client is scheduled for a CT scan with IV contrast. Which lab value should the nurse assess prior to the procedure? So what lab value should the nurse assess before this patient has this done? All right, the timer has started. I'm looking forward to your answers in the chat. What's the safest? I should have reminded you of that. Safety. Safety. What's safe? All right. I'm looking forward to your answers. I see them coming. I see you. I see you. All right. Looking for your answers. Once again, the lab value that is most important prior to CT scan with contrast. With contrast. All right. Answers are coming in. Answers are coming. All right. Time is up. And a variety of answers in the chat, but I will tell you if you were if you had the BUN on your mind, right? The BUN is a lab that is very important for us to check as nurses before patients go and to have these procedures and they're getting contrast because IV contrast can be nephrotoxic, meaning it can damage the kidneys. And when patients are given this contrast, it has to be excreted through the body, right? So remember, what goes in must come out. So when we give that IV contrast, where is it coming out? What's got to come out and be filtered through the kidneys. Again, we want to make sure that the kidneys are safely able to clear that contrast. So your BUN and creatinine, well, specifically your BUN is going to be your most important range or your lab there. All right. So good job. Next question. All right. A nurse is caring for a post-op patient. Which change in vital signs is most concerning? All right, answers are in, and it looks like there's a variety here. Most important change in vital signs, most concerning, would be in keeping with the strategy of your airway breathing. There is a change that happens with those respirations. Moving from 16 to 24, we've got a post-op patient. Their respiratory rate is increasing. It could be indicative of multiple things. Could include they're in pain, right? Um, Possibly hypoxic, okay, hypoxia. So we would want to also kind of check their pulse oximetry, but that wasn't an option on our list of answer choices. All of this could indicate early signs of sepsis and even a pulmonary embolism, right? Again, that's a complication of patients who are coming back from post-op surgery. All right, so that is the answer. Those respirations are what we would want to check up for the most, period. All right, and again, the other options, not so much. Remember that the temperature, we talked about this the other day. Remember the range takes us anywhere from 96.8 to 100.4. So this is actually, even though there is a shift here, it is essentially all of them are changes, all right? But the strategy is more of the airway, the breathing. BP heart rate is circulation, and temperature is, I would say, systemic. It still deals with circulation to an extent, but the respiratory rate is airway, right? Breathing. So we would want to concentrate on that. I did want to back up real quick. I know this is kind of it may be counterproductive, but I want to tell you real quick. The BUN, I want to tell you that we would be checking, right, that lab first, but I do want to connect that lab value for the BUN. What we're looking for is a good value of 10 to 20. The BUN's level is 10 to 20, and that resource that I attach tells you a way to remember the BUN being 10 to 20. It says a hamburger, right? You think of buns on a sandwich, right? A hamburger. Typically in today's world may cost you somewhere around $10 to $20 at a restaurant, right? So that's how you're going to remember that the BUN lab we're looking for that's normal is between 10 to 20. All right. So I wanted to make that connection so that you don't forget it going forward. All right. All right. That's an expensive hamburger, right? 10 to $20. That burger better be good. All right, moving on. All right, next question. We've got, which of the following lab results should the nurse report immediately? Immediately. All right, so which of these should be reported immediately? All right, let's go. All right, answers are coming in. Answers are coming in. Looking good, looking good. Keep them coming. All right, time is up. So this question is really just measuring your knowledge of those values, right? This is why we got to know our values. And each of those values are abnormal. They are, right? Our potassium should be between 3.5 to 5, right? So there's a slight variation there, but not too significant. Our sodium, remember that should be anywhere from 135 to 145. Some references will say 136 to 145, but just a slight deviation, not too much going on. So A and B have slight variations. Your hemoglobin, typically for your anywhere from 12 to 16, 18, and there is a slight variant. This is almost 11, so there's a slight variation there. But the calcium, right? Many of you chose D because you recognize that 6.5 is low. For our calcium, we're looking for anywhere from 9 to 10, 9 to 10.5, all right? Or 9 to 11, 9 to 11. So this was the biggest change or abnormality. So with that said, the answer that we would report would be this 6.5, and why, okay? Beyond it being out of the norm, critically low calcium can cause a patient to have muscle spasms, but then more importantly, affecting the neural system with seizures and even the cardiovascular system with them developing arrhythmias. So that must be addressed. And again, that's what you want to remember. So to remember calcium, just remember 9 to 11. 9 to 11 is where we want to be. That 6.5 is gravely low. All right, continue on. Oop, 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 oop. You might have saw it, maybe you didn't. Ugh, I'm sorry about that. But let's head on to our next question. All right, after a client has a cardiac catheterization, okay, procedure via the right femoral artery, it's asking us which finding requires immediate action, period. All right, immediate action for this patient who's had a cardiac catheterization to the right femoral artery. Which of these would require immediate action to take? All right. All right. So drop your answers in to the chat. Right. Looking good, looking good. Answers are coming in. What would be an immediate concern that will require immediate action here? All right, so it looks like multiple answers came in, mostly C's. I do have an option A. And the strategy really here is what's expected, right? An expected finding from someone who's gotten a cardiac catheterization. Now, for those of you just needing a quick reminder, it's a catheter, like how we have a catheter that is placed in the bladder, right? A Foley catheter. Well, instead of this catheter going into the bladder, this is going up to the heart, right? It's catheterized and going to the heart. So they have to enter the patient, right, to get there. And that could cause some bruising. That's normal, right? The fact that the patient comes back and we are now checking their pulses, a dorsalis pedis pulse of 2 is actually normal, right? And the BP falls within normal range. So the only thing that is really an outlier or abnormality here is the right foot, who's cool and pale, which means or signifies that this patient may have some poor perfusion, right? Going down that leg. Okay. And that's a big concern that we have to have for patients undergoing catheterization They usually will go through the femoral artery, which is kind of right in that groin area. So when the patients come back to us from having this procedure, we have to check distal of that femoral area, right? We have to check the pulses all the way down that leg. And if that foot itself, that's the most distal part, is cool pale, that could signify that we have compromised circulation, poor perfusion, that maybe there's an occlusion that's coming from that femoral artery where they went in to do that catheterization. This is considered a medical emergency. This is the safest answer and most appropriate answer to choose because we've got to do something about it, right? All right, good job. Let's head to the next question. All right, next question says, which client is at highest risk? Highest risk, okay? That means all of them are probably at some type of risk, but highest risk for developing respiratory distress. Respiratory distress. Who's the highest risk here? Y'all are fast. I think we might need to go down to 1 minute for the questions. 1 minute. I think that's a good thing. Make it a little fun. Make it even more fun here. 1 minute to me makes it uh, uh, like a speed Q&A, right? Get your processing quickly, right? 1 minute after this question. But who's at the highest risk here? Developing respiratory distress. And keyword is risk. What are the risk factors for someone's respiratory state to become depressed? Remember, depressed is slow down, right? Slow down, maybe under that 12 respiratory rate. So you're literally, from a strategy perspective, looking at what's a risk here that could slow down those respirations, okay? So if you are thinking, if you're thinking option A, then guess what? You are spot on, right? That patient with the PCA, that morphine, right? It's an opioid and it can depress or slow down respiratory rates or centers in the brain. So we have to keep our eye closely on these patients to reduce their risk. All right, next question. And I told you it's a minute now going forward for these questions. All right, but they're going to start getting a little bit more challenging. All right, so here this question says a nurse is caring for a client scheduled for a lumbar puncture. Which of the following findings should the nurse report to the healthcare provider before the procedure? Before the procedure. What's worthy of reporting to the provider for this invasive procedure known as the lumbar puncture? What is worthy of reporting? We're looking for abnormal finding, unexpected, something that is unsafe, could put this patient in an unsafe situation. Okay. All right, clock is winding down. All right. All right, answers are trickling in here. All right, good job. All right, so more answers in between B and A and B. Would it be more of a safety concern if the client reports a mild headache, okay? Emphasis on mild, okay? Versus the morning of the procedure or a client's INR 4.2. So if you are thinking what I'm thinking, B is going to be our concern. That patient may have a headache because they didn't eat, right? They've been NPO, but that INR is too high. That normal value for an INR should be anywhere between normal 0.9 to 1.8. Okay. If they are on like heparin or warfarin, rather, warfarin, their INR should be somewhere between 2 to 3. That's if they're receiving, right, anticoagulant therapy. Their INR is 4.2. That's high. So that means that this patient is at a higher risk for bleeding. And what are they going to do with the lumbar? They're going to do exactly what that P said. They're going to puncture. So that means that they're going to stick a needle in, right, into the spinal canal. And guess what could happen, right? What could happen? They can start bleeding, right? So it also puts them at risk for epidural hematoma, which is bruising, bleeding in that area, as well as neurologic damage, right? So this would be contraindicated and we would need to notify the provider. All right. So once again, INR 0.9 to 1.8, normal, right? For someone who is not receiving anticoagulant therapy, that would be all of us in this room, right? But if we're on warfarin or Coumadin, aka Coumadin, then 2 to 3 would be our INR level that we would say is therapeutic. And anything higher, bleeding risk, right? Which is a safety concern. All right, let's keep it moving, keep it going. All right, next question says a nurse is caring for a client who's receiving continuous IV heparin for deep vein thrombosis. Okay, that's a treatment. The nurse notes the following: an APTT of 115 seconds, whereas the normal is usually anywhere between 20 to 35 seconds, about 35 seconds. The patients also got bleeding gums during oral care and bruising. So this is a problem. So now they're asking us, what is the priority action here for this patient, right? What is our priority action here for our patient in this situation? What are we going to do about it? Problem, solution. What's going to solve the problem below? We got to help this patient now. Too much bleeding going on. All right, what could solve this problem? Your immediate priority action. If you could only do one thing right now in this moment, what is that one thing going to be? All right. And we're thinking safety, 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 safety. All right. Very good. Unanimous A is in the chat. I love it. Remember, the problem is that PTT level is too high, which puts our patient at risk for bleeding. But we've already got the evidence, right? There's the evidence that the patient is in distress. They're bleeding from their gums. They've got bruises all over their arms. So the problem is, what's the problem? The problem is what's causing? Why? The question is why? Those 3 letters. you know I love those 3 letters. Why? Well, it's the heparin. Is there anything going into this patient that's been added or subtracted? Well, we're adding a heparin. That's why. So, problem, solution. Solution is we're going to stop the heparin, right? Stop that infusion. And we're going to call the provider. That's what we're called the provider now. So, this would be a great choice. But guess what? Before we called the provider, we did something that was within our scope and also within our critical thinking, right? Clinical judgment pathway. We realized we had to stop it. All right. Once again, that 115 is way too high. Patients got symptoms, they're bleeding. We've got to stop it. And this is going to help to reduce further anticoagulation, right? Protamine sulfate. Please remember that. The antidote. It's the antidote. So it's going to come, but it's going to come after we stop, right? And notify the provider. So we may have to administer protamine sulfate. So just remember to tell yourself, remind yourself that protamine sulfate is actually our antidote. But once again, our focus and priority is to stop the infusion. So just as a quick reminder, your PTT in this question is abnormal, and there's a norm. We want to make sure what's normal. 30 to 40 seconds is about your norm, right? That's about where we should be. If everybody checked their PTT or PTT, guess what? If we're not on a blood thinner, it should be around 30 to 40 seconds, which means that if we cut ourselves and we started bleeding about 30 to 40 seconds later after holding pressure, right? We should have a little clot formed, right? Which is going to stop the bleeding. But patients that are on heparin on a blood thinner, they're receiving that heparin for therapeutic reasons to thin their blood, right? So we want it thin because we want to prevent new blood clots from forming, right? So with that being said, when we check their labs, their levels should be about 1.5 to 2 times the norm, right? So that's going to basically, if we doubled 30 to 40, that would put us somewhere around 60 to 80 seconds, right? Yeah, sounds about right. That means that if that patient cut themselves and bled, we held pressure, 60 to 80 seconds later, we should have a resolution, right? A blood clot, the blood should stop bleeding. I mean, the area should stop bleeding. Well, this patient, totally beyond that therapeutic range, all right? So takeaway, PTT normal 30 to 40 seconds. For someone who is on heparin, we want that doubled 1.5 to 2 times that normal range, all right? And just always remember, as a rule of thumb, anything over 70, so 70 seconds, right? An APTT of 70 seconds or higher definitely puts our patient more at risk of bleeding, especially spontaneous bleeding. Gums, they can bleed through any orifice, like their urine. We could see hematuria, blood in the urine, blood in the stool. They can be vomiting up blood, and vessels. They could bleed throughout their body, right? Spontaneously. So we've got to keep our eye on labs. A patient whose APTT is great, 70 or greater. Okay. All right. So very good. Good job. See, this is why we got to know our labs. Awesome. All right. And speaking of labs, here comes some more. All right. So here's our next question. It says a client with a history of chronic kidney disease. That means we've got damaged kidneys. Okay. Presents with the following lab values: potassium, 6.7, sodium, 132. BUN is 45, and the creatinine is 5.2. Kind of expect that, right? In the presence of damaged kidneys. But here's our question though. Which EKG finding is most concerning here? Most concerning. We put this patient on a monitor, EKG comes up. What would be most concerning here in this question? And for my February cohort, we talked about this week. We talked about this. We went over this Tuesday. All right, what will be most concerning here? Okay, you're making me proud. You're making me proud. You're making me proud. That means y'all been paying attention. I like it. All right, 7 seconds on that clock now. Most concerning EKG. We put them on a monitor. We see this. You already know. Those peaked T waves. Remember, T shouldn't be peaked at all. T should not be peaked. But if we saw a tall T wave, right, a peak T wave, that is indicative of hyperkalemia, which is what we saw in the question. The patient's potassium level was 6.7, right? And we know that our potassium, right, is 3.5 to 5. And a memory trick for your potassium, just FYI, is there are 3 to 5 bananas in a bunch, typically, right? When you buy bananas, about 3 to 5 come in a little bunch. That's how you're going to remember potassium, right? Because bananas are rich in potassium. But our patient's potassium is 6.7. Oh boy, that's a lot. So that is going to be a concern for us, particularly on the EKG, showing us taller T waves that's consistent with hyperkalemia. That is considered a medical emergency. It can progress to lethal arrhythmias. That's the problem. There is a likelihood or a potential that hyperkalemia with those tall T waves that can lead us to ventricular fibrillation or even asystole. Remember, I told you T waves naturally do not have any charge electrically, right? The T wave is the point after that, after the sequence, right? You've got your P wave, that's the atrium or attic, the contraction up there from the SA node. Then you've got the QRS, right beside it, which is reflective of your ventricular activity, the contraction. Both of those, P and QRS, that's your point where you have the electrical activity happening. But the T wave, that's the point where the T has no electrical activity. That's when the breath, right? The heart takes a deep breath, kind of recharging, only to do it again. But if we see the T wave having this level of activity, it's hyper, meaning, it's obviously from the potassium, this T wave could actually is now charged, like it's charged from this hyper state of potassium. It actually can now start to move or progress into a ventricular rhythm, like VTach, VFib, and death. So we don't play with hyperkalemia. We don't even play with hypokalemia, right? The low or high ends of potassium. All right. So please make sure as nurses you keep your eye on that, because again, that can be very harmful to patients. All right, whether it's high or low. All right, let's hit on. We're doing good. All right, question number 9. All right, it says, which of the following clients should our nurse see first? All right, keep your ABCs in mind and anything else that may help you to answer this question. Who are we going to see first? Who's the most unstable? Who has unexpected findings? Unexpected findings, unstable, unexpected findings, unstable. Again, we keep our ABCs in mind, but there are some cases where, let me be quiet. Let me let y'all work. 30 seconds on the clock. Who's the patient you're going to see first, or you want this nurse to go see first? You tell me. All right. Time is up. B's and A's. All right, we're going to walk this out. So, first person you'd see for patient A, PD, client has COPD, SpO2 of 89%, and they're on 2 liters. Is that expected finding for a patient with COPD? 89%? It most definitely is. Remember, we did vital signs the other day. They can be as low as 88% and be okay, right? 88 to 92%, that's normal for our patients with COPD. All right, so A would not be your patient you'd see first because dealing with some normal things. That's normal for them. All right. B, client with pneumonia and a respiratory rate of 26. Now, do we expect a patient who has a respiratory condition, such as pneumonia, it's an infection, right? Characterized by exudate, secretions, mucus, all of that. That means that the patient's lung area is compromised a bit. So their normal respiratory rate, we may not see normal. We're likely not to see normal. Not for pneumonia. So the fact that their respiratory rate is a little bit more accelerated, we kind of expect that. And I know it's airway. I know it's breathing. But guess what? This is not our priority because it's expected. It's an expected finding. Yes. Now that we're not going to go see them, but we're not going to see them first because we kind of expect that. Yep, first choice. Yes, 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 yes. All right, let me skip over Cinco de D. The post-op patient. Post-op. Look at the temp though. Remember, the range for your temperature is normal, 96.8 to 100.4. That is your range of normalcy. 100.4 is okay in the sense that we're not gonna be like, oh my gosh, panicky about 100.4, right? And is it expected? I wouldn't say expected, but it is something that it's a possibility. Yes, certainly risk because it was invasive. How did they get the appendectomy removed? They had to go in, cut, remove, right? Take some things out, move some things around. Hopefully not, right? Hopefully they just took the appendix and closed them back up. But a temperature is something that we do get concerned about. But the 100.4 is not enough for us to be like, I'm gonna go see them first. But our patient with chest pain, remember I told you from the jump, chest pain is never okay, right? Until we can rule out that the patient is not having a what? A heart attack, right? The C in ABC is circulation, right? So this patient who is having a C issue, right? A circulation issue, right? Chest pain. But here's some evidence that lets us know that that patient's chest pain is probably more than just acid reflux. It's just a little bit more than just some acid reflux, right? It's some belching that's causing them a little discomfort. It's not, because that troponin level, my friends, my nurses out there, that is excessively elevated, which indicates our patient is probably having what? And I see it in the chat. Yes, a myocardial infarction, because that number, 3.8, is high. Anything above, for troponin, the level above 0.04, y'all, that's not even like 1. That's a 0.04. Like we should, anything that over that suggests myocardial injury, that something is going on. And the 3.8 is super, super elevated and it requires immediate evaluation for an MI. What would be the immediate intervention? If this patient was actually founded to, matter of fact, I'm gonna give you 2 questions for this question real quick. Let's say in the presence, stay with me, okay, critical thinking, in the presence of this 3.8 troponin elevation, we put them on an EKG. We did an EKG, performed an EKG. What, does anybody know the EKG rhythm? If we saw this particular rhythm or thing, that would also indicate the patient's having myocardial infarction. What's the EKG that we look for that confirms a possible MI here? So we got the blood on the screen, right? Troponin is elevated, right? 3.8. But we do an EKG and we see this, that would be indicative of myocardial infarction. I'm gonna help you out. If the S and the T were elevated, so an ST segment elevation, I see you, Kim, yes. ST segment elevation. So you got the P wave, the Q and the R and the S. But the S would be, instead of the Q and the R, the R is at the top, and then S would kind of come drop down on the kind of here. And on the EKG, the QR, the S would be elevated, and so would the T. So it would be like this. You would see like a little hump or notch in it. So ST segment elevation is consistent with myocardial infarction. Okay, so that's a takeaway here. So we got troponin levels that are greater than 0.0.4. That suggests injury, right? In an EKG with an ST segment elevation also can be confirmatory that this patient is in fact experiencing myocardial infarction. All right, and here's my last question to you. What are we going to do about it? What's the number one intervention for a patient what can solve this problem? And I do see it. So morphine, oxygen, nitrates, aspirin, all of these will also be a part of treatment for the patient, right? MONA for the acronym. But a myocardial infarction, think about the patho. It's an obstruction. It's a block from a thrombus, a blood clot. And it probably came potentially from the lower extremities, right? Possibly from a DVT. I don't know. But it's a blood clot and it's lodged in one of the vessels or arteries of the heart. Okay. So patho-wise, if this is a large, if it's if it's blocking blood flow, essentially it's blocking blood flow. Okay. So the number one thing that is the treatment for a patient who's having an active heart attack, STEMI alert, they go where? Where are they going? Nope. They have to go where to get it unblocked? Yep, you getting hot. Rashonda, come on, girl, now. Come on. I see you in the chat. See you in the chat, girl. What are they doing through that femoral artery? They're going up through the femoral. They're going to take them to this place, go through the femoral likely, and they're going to thread this up to the blank. The cath, yes. The cardiac catheterization. That's the number one intervention for a blocked artery, right? Particularly cardiac artery, a cardiac vessel that's being blocked with the clot. The cath, the cardiac catheterization. Why? Because when they go up, thread through the femoral, so they're going to come low, go up high. When they put the catheter, they're going to find the location where there's a blockage. They're going to put the catheter right in that blockage. And guess what they're going to blow up? A little balloon, right? They're going to blow a balloon up, little balloon, just like the catheter, the tip of a Foley, right? You know, when we put that Foley in the patient, we have to put some fluid to blow up a balloon up in there to keep it anchored. It's the same concept. They put the catheter, PCI, percutaneous, intervention there. They're going to put the catheter where the blockage is, blow the balloon up, boom. And now the balloon is now opening up the area that was once obstructed. And then sometimes patients need stents to kind of keep that vessel kind of stayed anchored so blood can now continue to flow through. Yes, that's the treatment. Yes, cardiac cath. And let me tell y'all something. When they have these catheterizations, typically the pain that they were having from that excessive chest pain that they were experiencing before that catheterization disappears. It goes away, dissipates because the blockage is now restored and the blood can flow through. It's almost like cars, like here in Florida, there's a lot of tolls, which they're now changing. But the toll, when you get to a toll, your car comes up to a toll, you can't pass that toll until that lift comes up for you. And the toll, that space there, right? That's the equivalent of a thrombus, a blockage. We can't keep flowing or going until we get a lift. And that lift in this case is the catheterization, the cardiac cath with the balloon, stents, etc. All right. And then for those patients who did have that procedure, okay, they're likely then also going to be placed on heparin, right? Because heparin and anticoagulants are placed at that point to prevent new clots from forming. Okay. Heparin Warfarin, they're not going to dissolve current clots. They have nothing to do with current clots. They can't touch it. They can't do anything for current clots, but they can do for new going forward. Yes. Heparin, yep. All of those, calcium channel, all of that is great. Perfect. And remember, if this patient comes back to us, we got to monitor that femoral area where they went up into the chest to do that catheterization. We got to check pulses. We got to also keep them on a monitor so we can be looking at their rhythm. They took a catheter up in the heart, right? So it is a risk that they could have some dysrhythmias, right? Or some things going on when they return from the cath lab. So we're just kind of keeping an eye on it. All right. So I know this question kind of spun out into more, but I just want to get your wheels turning. As a recap, troponin should be less than 0.04. Elevated means the patient's likely experiencing a myocardial infarction. EKG is also diagnostic. If we see an elevated ST, segment elevation, that's also consistent with an MI or myocardial infarction. And then the intervention, number one, is cath lab, cardiac specifically, cardiac cath lab. They're going to be whisked away to the cath lab so they can go on up, thread that catheter up to the heart, and boom, open up that lift gate so blood can flow through. All right, so that's how we're gonna manage it. Yes, awesome. Yes, ma'am. You got it, darling. I see you. All right, we're closing up. We're getting close to the end here. All right, let's hit on to the next one. All right, so this question says a nurse is caring for a client with suspected pulmonary embolism. Oh boy. Which diagnostic test is the most supportive of this diagnosis? What supports a pulmonary embolism? We think our patient's having it. Which of these tests are going to give us clarity on just that? Right, answers are coming in. All right, answers are coming in. Yes, yes. Awesome. All right. So I see A's. Yes. Y'all, I need you to commit that the D dimer is your lab test of choice that does confirm blood clots. Our D dimer should be less than 500. Okay, so a normal for all of us in this room that don't have any blood clots going on, right? We should have when we have our test drawn, it should be anything less than 500. Okay. And maybe you can remember that because dime, I don't know, dimer has 5 letters. 1, 2, 3, 4, 5. Hello. 500, less than 500. That might help you, right? D-dimer. But in this case, patient has 1100. That's a high, indicative of possible or confirming the presence of thrombolytic or thrombotic activity, right? That's what a pulmonary embolism is. It's a thrombus. It's a blood clot. That's where in the pulmonary system, pulmonary of vessels, vascular area. So, which most likely got there because from the lower extremities, moving the blood back up to the heart, right side, ends up in the lung. Okay. So, number one, remember also with pulmonary embolism, if we suspect it, chest pain, an acute change, a sudden change, lets us know our patient is likely potentially experiencing a PE, chest pain. That's like your number one like hallmark. And once again, we draw a D dimer and it's greater than 500. We got 5 letters in the word dimer. Then we most likely got a patient that is likely experiencing a pulmonary embolism. We're going to make sure that we understand that they're going to likely need a CT scan or further imaging to confirm it. But oxygen is also an intervention we want to think about giving to that patient. All right, we're coming down the stretch here. We've got this question says a client post-op day 1 after an abdominal surgery, and they're showing the following vital signs. Temperature 99.5, heart rate 122, respiratory rate of 26, and a BP of 102/60. Their SpO2 is 94% as well. They also have a symptom of increasing confusion. What would be our priority action? Problem, solution. What would be our priority action that we would do that could solve this problem? Potentially. Yeah. Post-op patient, day 1, abdominal surgery. Oh, I got to start the timer. Oops. All right. Out time. All right. All right. All right. I am seeing answers coming in. This is a bit of a tricky. Okay. 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 What could be happening with this patient? Their blood pressure is low. Their heart rate is up. So these two are probably compensation. This is a compensation thing. So it looks like we might have a couple things going on with this patient. Yes. O2, blood pressure low, heart rate high, right? One is going the one way, the other's going the other. So that's a circulation issue. And they've got an oxygenation issue. And they've got a neurologic change. Y'all, I love that you have all looked at the ABC side of it and the oxygen sounds good. But that's only going to possibly fix the 94%, maybe address the respiratory issues, but it's not going to fix the heart rate and the blood pressure. Something is going on, y'all. The patient might be developing sepsis. So let me tell y'all, instead of the oxygen side of things, it actually is checking the C. I know y'all like, oh my gosh. If we're thinking sepsis, what can actually give us a confirmation on it is the lactic acid lab, as well as checking the complete blood count, right? Complete blood count makes sense because we've got low volume here. So are they bleeding out? Are they bleeding internally? They had abdominal surgery. So CBC will let us know how much blood cells, right? Red blood cells, if it's low, that means that maybe they're losing volume. The lactic acid will also let us know if the patient is developing or has developed sepsis. Okay, so to notify the surgeon, not just yet, we'll hold on to that, but reassessing, no, because reassessing means we're not doing anything about a problem that's inevitable. There's a problem, we need a solution. B is not our answer. Check CBC, then you ask yourself, what will CBC give me? What information will it give me? This is assessment too. The word check is assessment, right? Assess. It's going to give me information about my blood count. My lactic acid lets me know sepsis potentially. Applying oxygen is implementation. And once again, could it fix the respiratory things? Yes, but there are other outliers here. There are other problems here. If it was just an oxygenation issue, then this would make more sense to me, the NARA breather. That would make more sense. And we just had issues with the oxygenation, the SpO2, the respiratory rate, everything else was normal. Then it makes sense that your solution would be oxygen or respiratory specific. But you've got other things, plus they've had surgery. So everything points to, hey, let's get these labs, right? Early sepsis is possible, right? Lactic acid is a indicator of tissue hypoxia and should be evaluated to guide us with next interventions. All right, I'm looking at my time. It's 1 o'clock. I will tell you, I had questions up to 15. I had 15 questions. So I am prepared to continue. If you have the time, I'll stay. We're at 12, so we're like right there. So I'm thinking maybe 15 more minutes if you have it. But let's do this question. This is gonna test our. Yes, I see you, Rashonda, darling. I see you. Awesome. All right. Yay. Kim says, yes, y'all got time. If y'all got the time, I got the time too. All right. So let's do it. NCLEX, we're going after it. For those of you who are retested, we're going to get past it. And if you're not retested, this helps. This helps, right? This is helpful, hopefully. All right. Our question. 3 more questions to go, and this will take us to the end. All right. This patient has end-stage renal disease. All right. So that means that their kidneys are shot, damaged, right? End stage, oh boy. And they're presenting with confusion and fatigue. Okay. All right. So what do they need us to answer? They give us ABG results. All right. And so here we go. We've got an ABG of a pH of 7.28. We've got a PaCO2, which is all about our, nope, not going to tell you. PaCO2 is 38. HCO3 is 16. And our PaO2 is 92. Ouch. All right. So what condition? What's the interpretation of this ABG? What would you say this patient is dealing with? Is it respiratory? Is it metabolic? Look at their diagnosis. Okay. The diagnosis they have, the medical diagnosis. And then also look at their remaining labs. All right. Remaining information. I won't give it away. Let me see what you can do with it. What is happening here? Remember the ABGs, a lot to do with memory, muscle memory. Remember your pH influences if this is acidosis or alkalosis. Y'all gonna be reduction of risk potential masters. All right, answers are coming in. Yes, all right, all right. All right, all right, all right. So time has expired. All right, I see answers in there, and I am very, very happy to see what I see. First and foremost, strategy, nothing telling us anything related to respiratory anything, right? They're not, this is not a respiratory. They have end-stage renal, which is really metabolic. Renal disease is metabolic, right? A metabolic condition. The first thing when we interpret, go to the pH, right? pH, the norm should be 7.35 to 7.45, right? And anything low, on the low side, right? On the low end, how low can you go? Well, if you move lower than 7.35, which 7.28 is less than 7.35, then that puts us at acidosis, right? Acidosis. So that means we can get rid of C and D because they're not alkaline, they're acidotic, right? And then we look at our 2 remaining values. The CO2, the normal is 35 to 45. So guess what? We don't really have a respiratory issue because this is a normal value, right? This is within the normal range. All right. And so is that PaO2, which should be anywhere between 80 to 100, right? So our respiratory values check out. They're great. This is not a respiratory issue, but this HCO3, that range should be 22 to 26, and it's low. All right. So once again, when we also remember the acronym ROME, right? Respiratory opposite, but metabolic is equal, ROME, right? The pH is going low, and then the CO3 is going low. So they're going in the same direction, going down. All right. So guess what? All in all, this puts our answer towards metabolic acidosis, option B. Very good. I'm proud of y'all. And once again, the renal failure gives it away. Because remember, the kidneys are what's releasing the buffers, right? The buffers are what's alkaline, right? And so if the kidneys are shot, it can't release the buffers to kind of regulate the body, which keeps that body in a very acidotic state. All right. So metabolic acidosis is our answer. Good job. That resource I gave you or attached to the email I think it's on page 3. It goes over ABGs and a little bit of a few tips and tricks to remember. All right. All right. We are coming down the stretch. All right. We got a couple questions left. All right. Let's do it. 13. And we're going to test you again. Nurses caring for a client experiencing acute anxiety. I bolded that for a reason. And the client is breathing. Keyword breathing rapidly. ABG results are pH 7.48, PaCO2 30, HCO3 is 24, and then PaO2 is 96. So what is this interpretation? What would you say? What is the interpretation for our patient who is dealing with a little anxiety? She's anxious. Could be for many reasons. But what's the interpretation here? All right, 20 seconds to go, 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 go. All right. Y'all are making me proud, making me proud, making me proud. All right. Woohoo. All right, all right, all right, all right. D's are coming in, and guess what it is, y'all? It is D, baby. That high pH of 7.4 or greater than 7.45. I think our patient's was 7.48, makes them alkaline, right? And then the fact that they were or had lower CO2, right? Their CO2 was 30, if I recall correctly. Yes, that lets us know we got a respiratory issue and it's alkalosis, right? And remember, respiratory alkalosis and hyperventilation, right? Hyperventilation, they go together. And that's why I was intentional about bolding the rapid breathing. All right. So commit to memory. Respiratory alkalosis equals that hyperventilation that's tested on the NCLEX quite a bit. And again, we're going to be dealing with patients who are naturally going to probably have or present possibly revved up, breathing fast. Could be because of anxiety, but could be because they're in pain, right? Pain increases respiratory rates, right? And so does panic attacks. So we have to keep that in mind. We don't want them shifting into this state. So we have to calm them down and maybe give them a brown paper bag so that they can blow into that. All right. So that's going to be the intervention. All right. 2 more questions to go, and we are almost there. Woohoo! All right. So EKGs, once again, part of this section. What's this rhythm? How about that? And and then more importantly, what are we gonna do about it? What are we going to do about? Oh yeah, and it's Xanax and Ativan. I know that's right. Name that rhythm. And remember, if one part is wrong, the whole thing is wrong. All right? Name that rhythm. All right. Answers are coming in. Answers are coming in. Okay. Just real quick, can you guys still hear me? Can y'all hear me? Just confirming that you can hear me. Awesome. Y'all can hear me. I can be heard. All right. 4 seconds left. All right. Yes. So for those of you in my Tuesday, February cohort, we went over EKGs. We went over this, right? Remember, we're looking for P waves, and I don't see not a one. P waves means that the lights are out in the attic, right? So this right here is what we see is QRS. That's downstairs activity, right? That is your specific to the ventricles, right? So this is all ventricular in nature. Could not be called atrial fib or even this block, heart block A and B. This is not consistent with this rhythm. So now that puts us down to C or D. And once again, I'm very pleased to see that most of you did choose correctly. And remembering that your ventricular tachycardia, let me talk about fib first. Ventricular fibrillation is chaotic. It's chaos. Think about fibrillate, the word fibrillate. Just think about a bunch of like firecrackers fibrillating on the ground. Pop, 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 pop. So it would not look as clean as what we see there. Regular, we see very clean. We just see a very wide QRS that has a very regular presentation. And that is consistent with D, which is ventricular, definitely ventricular. That's QRS. That's your downstairs activity. Um, it's VTAC. And what do we do for VTAC? We defibrillate. And we also give them CPR, right, for perfusion, because with this VTAC, it can be with a pulse or it can be without a pulse. The fact that they've added CPR means that this is pulseless VTAC that we see. And the drug of choice is epinephrine. And remember, epi causes will do two things. It will adrenalize the heart to try to help it to rev up, to start back up again. And epi also impacts perfusion. Remember, epi is a vasoconstrictor. It tightens up, right? And so it will help with volume. Patient's heart stops beating. Think about all the blood that's still in their body, in the periphery, right? All it's that's out there in the legs, the toes, everywhere. It's all this blood just pooling, just sitting there. It's not moving because the heart has stopped. So epi, when you give it for cardiac arrest, epi's gonna tighten those vessels, those blood vessels. And that tightening is going to assist all that blood that's just chilling out there in the periphery is going to assist it to come back up to the heart, right? And why do we need it at the heart? Well, if we're doing CPR, CPR is perfusing. CPR is nothing more than just perfusion. We're pushing down to send that blood up to the brain, and we're releasing, which lets that blood from the brain come back to the heart. So when we're doing compressions, it's perfusing the most important organs that need it the most, right? The heart, brain, heart, brain, heart, brain, heart, brain. And then when we get that volume, right, assisted by epinephrine that helped us get that volume back up, it gives us more volume to perfuse those two organs. All right. So this answer is, in fact, ventricular attack. And we are going to do those things listed above. Defibrillate, that is our priority. And remember, this is electrical. These are pops. This is an electrical issue. We need a solution that's electrical. Defibrillation is electric, right? We're going to fight fire with fire, electric with electric. So that's what we're going to do in this case. And yeah, and we're going to hope for the best. We're going to hope for the best. All right, so very good on on that question. All right, final question of the day. Final question of the day, y'all. Y'all done wonderful. You've made me proud. I had to slide in some pediatric vital signs. All right, yes, I'm ending it with this. Right? This question says a nurse is assessing a 6-month-old infant during a routine checkup. Which of the following vital signs should the nurse report to the provider immediately? Immediately. 6-month-old. Yes, yes. We went over this on Tuesday's class. Um, if you've been in a previous class of mine, we went over this too. Vital signs for peds. Got to know them. Got to know what's normal, what's not. All right. What would we report immediately? That 6-month-old patient. Oh boy, got some of y'all stumped. Oh my gosh, just 5 seconds left. Oh my goodness. All right. Yeah. So, note to self, if you struggle with this question, it's probably a good idea to refresh on those vital signs for pediatrics, which come straight from your book. I will tell you that the answer here, so for a 6 month old, all right, we went over this on the other day, 6 months, not neonate, right? Not infant, but I'm sorry, not newborn. Okay. So it would be not the first set of vital signs that we went over, but the second. Um, infant up to 1 year. Okay, that's the second set of vital signs. So for our infant in this age 6 month old, the respiratory rate. Hold on, I'm sorry. So the heart rate for an infant is between 90 to 130 beats. So the heart rate here is fine. Fine, no problem. So that's not a problem at all. The temperature, remember, for our temperature, anywhere from 97 to 99. Remember, you heard me say 36 to 37. Temp is fine. No problem there. Okay, so A and C are out. And for our um for our blood pressure readings for this age, 90s over 50s or 90 over 50s, diastolically, they're fine. 90 is their norm, 90 over 50. So it's 88. It's not too bad. This is actually okay. This is considered to be normal right here. Guess what's not normal? This respiratory rate. So for the 6 month old, we look for 20 to 40 breaths per minute. So the 20 to 40 breaths is our concern here. And your question is why? Why are they breathing so fast? Right? It's more than a normal. And we know fast breaths can lead to a metabolic issue like respiratory. No, sorry. It could lead to respiratory alkalosis, right? But it could indicate that they are in some type of distress, right? Or something, right? Something's happening. Is there a blockage? Do they have some mucus there? Are they choking on something, or there's an obstruction? Respiratory rates that are higher in this age group could also indicate infection or that metabolically something is going on. All right, so keeping in mind that in infants, changes in respiratory rate are an early sign. That's one of the earliest signs of deterioration. And once again, our infants can't talk to us. They can't verbalize that they are in distress. So we have to be very in tune and sync to what their vital signs, right? The changes that are happening. That's very crucial to prevent complications like hypoxia. All right. Woo! Any questions from the room, in the room, from the group at all? Any questions that linger? Anything you want to mention over? Yay, yay, yay. Was this helpful? Was this helpful? Did you enjoy today's review? I'm hoping so. I'm hoping so. Yes, yes, yes. I love it. I love it. I love it. I appreciate y'all. I just want to make sure too that you are remembering that I said that there is an attachment. So just really quickly, the attachment that I sent to the email. It looks like this. It's pretty cool. It's 5 pages. It's once again tricks. It's electrolyte lab values, tips to remember. It's giving you some ways to kind of remember your lab values, specifically to electrolytes. Um, it's giving you also the option to remember some of your renal labs and some tips to remember those, which is good. This is where I got the BUN, right? 10, 12, $20 at a restaurant for a burger. You think each kidney is 0.6, 0.6 equals 1.2. So that's the range for your creatinine levels on your kidneys. Um, it also goes into those ABGs, some tips to remember. There's your pH, your CO2, O2, and HCO3. And then that ROM, right? Respiratory opposite, they go in different directions, whereas metabolic, they go in the same direction. So these are some tricks there. And then it finishes out with your lipids, labs, and tips to remember. We want our cholesterol less than 200. It talks about our LDL, the range we want. You want low LDL and you want high HDL, right? So this is your numbers. And then it goes into your glucose, right? 70 to 100 is normal, but your hemoglobin, anything less than 7, right? 7 days a week we eat. That's how I remember it. Lucky 7. Once again, that's what we want as a norm for our patients. And then it finishes with your commonly tested lab values. These are also on the packet that you have too, the simple packet that I provided. But I just feel like this was a really nice, clean, simple, colorful, creative way of presenting. So I came across this resource, and I'm wanting to share it with you all. So hopefully you'll find this to be helpful. It is once again attached to the email that I sent out. Um, this very last email reminding you of today's session as well. I think I'm also going to upload it to the hub as well. So I'll put it there too, just in case. I'll put it under week 7 for my peeps that are in the February cohort. So I'll upload it there as well, just so that it's in there too. All right. So with that said, I want to finish up, give you back the day. For those of you who are testing, I want you to just remember the goal is hashtag pass NCLEX for 2025, and you can and will do it. Why? Because you are unstoppable and you can get this done and will get this done. And we're going to do it together. So I thank you so much for your time today. I appreciate you. Join me again. um, yes. And Roshana says, y'all got it. You got it. You have it. You do. All right. So please remind yourself of that. Pat yourself on the back for the work you're doing, your hard work you're working. I see you. Keep it up. Can't wait to connect back with you. Um, um, for our next session, our next Thirsty Thursdays will be on April the 10th. So it'll be another session, fun, enjoyable. If you can join me there, do it. I'll see you then. I'll also make sure that I'll send out email reminders to keep it on your radar. All right. All right. It's been my pleasure, y'all. Enjoy the rest of your day. Again, y'all got this. All right. All righty. Have a good day, guys. All righty. Take care.